Thank you. I'm really honored to be here, actually. It's good to get back to Louisiana and get some good food. You know, funny story, Dr. Katz, who probably doesn't even remember, because I was a third year or fourth year med student, and I actually called him. He was in the middle of the trenches at Johns Hopkins doing orthopedics, and I had about 1,000 questions to ask him on how to get into orthopedics, where I should go, pretty much anything I could think of. And I think he called me back, you know, like 9 p.m. one night. He had been on call the whole night before, worked the whole day, and so he really has helped influence my career as another number as a med student, but now it's nice to come full circle and be able to have this opportunity. I'm currently at University of Texas, Houston, in Houston, Texas, doing something that I love doing, and so it's great to share this. It's a great opportunity for me, and I really appreciate you sitting here. Let me just get a feel of the audience. How many of you have a hip? Oh, wow. I didn't realize there were so few people with hips in this audience. Okay. How many of you are physical therapists? Okay. How many of you are athletic trainers? All right. How many of you are physicians? Okay. How many of you have a hip? Let's try this question again. Great. A few more people got hips. Okay. That's good to know. So everybody's familiar with at least a hip, having two. Most people have two of their own. And then most of you probably have seen hip injuries, take care of athletes with hip problems. It's hard to be an athlete without a hip. There are definitely people who do it, but most of the time, if you're an athlete, then you have a hip, and if you're not an athlete, you still have a hip, and a lot of you have pain from it. So we're going to try to talk about some of these sports-related injuries, but for me, the most difficult part, and maybe y'all are great at hip problems, but for me, it's a deep socket, and it's somewhat of a black box at times, and so I wanted to take a step back and really define some of the problems in the hip, how to examine it, and then give you some examples of why you can get 2 or 3 very different diagnoses from similar complaints. So I have no disclosures. So the objectives, we'll define the hip pain, discuss some of the common causes, some of the key exam findings, and some of the treatment approaches. I mean, this isn't really going to be a cookbook of how to take care of a patient with a hip problem because I find that there's so many different nuances, their height, their weight, their athletic activities, their age, their previous conditions. There's no one answer to take care of it, but hopefully this will give you kind of an overall approach. And then certainly some pitfalls. We don't always do the right thing for the patients, but it's nice to not do the wrong thing or do no harm. And so I think if you kind of know maybe some red flags, you can have a safe approach, and you can safely expand your skill set and your comfort in treating these athletes without or minimizing the chance of making them worse. So hip or hip pain, it's a complex multi-layered anatomy. I really love the knee, and it doesn't mean that it's simple, but you can press on a lot of the common areas and the anatomical places in the knee that can help lend you a diagnosis. Where the hip, as you can see on this MRI, you know, this is the soft tissue envelope, and you really can't directly palpate the bone on any portion. You can get to the greater trochanter, which is out here. You can see this is the femoral head. This is fluid inside of it. This is the joint surface. This is the acetabulum, or the bony socket of the hip. And then you've got this multi-layered anatomy of muscles in the back, muscles in the front, and then also the stuff over here, which I didn't put on the PowerPoint because I don't even know what's inside the pelvis. That's another field, but there's certainly hip problems that can originate from that. So gynecologic, gastrointestinal, then you can have problems with the blood vessels, and neurologic. We're going to focus mainly on the musculoskeletal, but in your mind you have to be thinking about all of those problems. So if you see a female athlete with hip pain, is it an ovarian cyst? Is it a GYN issue? I mean, you can't take it and isolate it. Okay, they have a hip problem, it must be a musculoskeletal issue. So you have to make sure you take that global view, at least initially. This is a great image, and certainly most of these, or almost all of these in here, they don't belong to me. I've tried to cite them as best I can so you know that they're not my original ideas, but I think they're helpful, and I think they're in your handout. So this is an article back in 2008, and it takes hip disease as a big circle, and it talks about the normal hip is hip homeostasis. And they use that because they don't want to use normal, because normal has such variability. So hip homeostasis could be hips that are somewhat different, but they're not painful. And then what we try to do, hips that get out of line, basically they kind of fall into this outer circle. And what we are trying to do is provide treatments to push them back in. And so we have factors such as age, activity, biology, injury, their tissue laxity that are trying to drive the hip out of homeostasis, and then through rehab or surgery or change in activity, we're trying to bring them back in. The two main ones that we'll focus on as orthopedic surgeons are two entities called hip dysplasia, or developmental dysplasia of the hip, DDH, which most of you have heard of, or impingement, FAI, which probably everybody's heard of if you take care of any hips at all. And the two types that we'll talk about are CAM and pincer impingement. But these are conditions that try to bring the hip into hip disease, and then we're going to try to get them back into this green area. We'll focus on the intra-articular conditions, and there are several here that I've listed, certainly not an exhaustive list, but anything from the labrum, the cartilage, the ligaments, the capsule. You can have tightness in the hip similar to frozen shoulder. You can have impingement, and certainly we're going to focus on that. Loose bodies or even tumors can cause pain in the hip. Then right outside the hip, which is difficult to tell the difference at times, you can have any type of tendonitis or avulsion injuries. Snapping hip, which I know people have seen as my hip dislocates, is the common complaint. Abductor tears, osteitis pubis, which is actually the symphysis or the center part of the pelvis that can be irritated. Athletic pubalgia, which is another black box that I certainly can't claim to understand, but can cause debilitating hip pain, and we usually get help from our general surgeons in that area. And then nerve compression, which I think is starting to evolve as well. So for me, the hip pain, the key is trying to localize it on the history. So we're trying to decide, is it anterior, is it posterior, is it lateral? There's a C sign. Has everybody heard of the C sign? Anybody heard of it? Basically, this is where my hip hurts. So can everybody see that? Basically, they cup their hand like a C and they put it on the side of their hip. A lot of times that's intra-articular in nature because they're trying to describe that it is a deep pain within their hip. But you can have anterior, posterior, and lateral. You want to know, is it a discrete injury? So some people have years and years of hip pain, and some people say, I was doing fine, I did this certain maneuver, and now I have hip discomfort. Does it cause any limitations? No, I run 3 to 5 miles a day, and it's sore afterwards, or it's sore after I sit, but when I get up, I have no problems. Can you recreate it in the office? So the snapping hips, a lot of times they can say, yeah, watch, here, it's going to dislocate, and they do this little kind of gyration, and their IT band snaps, and you go, okay, good, well, at least it's not really dislocating, and they kind of give you this puzzled look like, well, what do you mean it is dislocating? And then can they do anything to keep it from hurting? So some of them will tell you, if you're just listening to them, well, if I don't flex my hip up and turn it in, it doesn't hurt. And you're thinking, oh, okay, well, that's helpful. Or if I don't do this dance maneuver where I hold my hip up and my leg in my hand for 6 minutes at a time, it doesn't hurt. And you go, okay, well, that's going to be hard for me to help. And then you want to know any associated symptoms, mechanical symptoms, locking, catching, popping. Do they have the snap, or do they have a feeling of instability? And that's difficult because you can't really, do you have any instability? Like if I'm asking you guys that, do you have any instability, and you're in the medical field, you may go, well, what are you talking about? I mean, relationships or family? What, I don't understand. So try to, does it make you feel nervous? Does it make you feel like your hip's going to do something that it shouldn't do, going to go somewhere where it isn't supposed to go? Sometimes teasing those out is actually more difficult, and I'm just kind of like, oh, okay, maybe you don't have any instability. So next, after you've gotten this history, you're trying to do a physical exam on them. The general exam is important, and then there's there's an article which I've referenced, you can reference number 1, it's a compartmental-based exam. And the reason it's helpful for me is it kind of helps me remember all the parts of the exam. And so if I break it down, I'm pretty simple-minded, and so I can kind of say, okay, is it intra-articular, is it medial, is it lateral, is it posterior, is it anterior? And getting a sense, I mean, we evaluate these as surgeons or physicians, and then a lot of times we say, okay, we need you to see the athletic trainer, we need to see the physical therapist. We don't always have the right answer when we're sending it to you, and so having a good approach to it will benefit the patient. At the end of the day, we all want the patients better, and you guys, particularly if you're on the front lines from a rehab standpoint, are seeing these patients 2 and 3 times a week. We see them 10 or 20 minutes one time every 6 weeks in the office. I know I'm not that good, and sometimes I can't get that diagnosis until I've worked with them. You get them on a treadmill, and then it recreates their pain. You say, well, that's why you're having pain. You didn't even have any pain in the office for that same reason. So having a good understanding of a physical exam can be invaluable in the rehab standpoint. So if we break it down into these 5 areas, we start with a general exam. So gait, range of motion, active versus passive. You're looking for stiffness. You want to check their reflexes, right? So not all hip pain is hip pain, so you want to make sure it's not being referred from the back. And then you want to get a good neurovascular exam. For me, intra-articular is that's kind of how I start. It's a nice way, once they're laying down on the table, to roll their hip back and forth. It's called a log roll. You want to see if that causes discomfort. And that's pretty sensitive for something going on inside the hip, because it's not really stretching the muscles, you're not stretching or tensioning the nerves, and you're not having them actively fire anything. And so if they're having discomfort from a log roll, then usually the irritation is from inside the hip. And then the now famous or infamous impingement test, which is flexion, adduction, and internal rotation, and that's where you're bringing their hip up to 90 degrees of flexion and rotating it in and asking them if it's painful. You have to be careful there. If you find a colleague that's gullible or friendly and you do this test, most of them have some discomfort. And so the key with this is not, does this cause you discomfort, it's, does this reproduce your symptoms? So if the ones that are the most valuable, if they go, oh man, that is exactly what happens whenever I'm doing that activity, then I think that's incredibly sensitive. And then if you're looking for anterior instability or apprehension, that's a little more difficult, but that's more the extension position, and then you're externally rotating, and you're trying to essentially bring their femoral head out of the front of the socket. And usually they get those kind of big eyes like, whoa, what are you doing? And then that can be a positive test. It also irritates the labrum or the rim in the front, and so it can cause pain there. If we move to the medial side, so basically knowing your anatomy, the adductor muscles, you're testing them. Very simple stuff. Pain with resisted adduction or tenderness directly over it. So I have a lot of hip pains that are groin pulls or adductor insertional strains. The iliopsoas, I think, is somewhat difficult. It tends to have some tenderness to it, where the intra-articular stuff is not as tender, and it's worse with hip flexion. And if you can reproduce groin pain when you're resisting them doing their firing of their iliopsoas. Then snapping hip, basically they come from a position of flexion, external rotation, and abduction, and they bring their hip in. So it's this position down to that position. And that was my arthritic knee that popped. That actually wasn't my snapping hip. It can also be caused by the tight iliopsoas. So then we move lateral. So what conditions can we see laterally? Trochanteric bursitis is probably the most common, and it's actually a little bit refreshing whenever they're really tender laterally, because for me that makes it a lot more straightforward. We have Ober's test, which can be underlying IT band tightness, which we try to test for, which I do with the knee inflection. And then you bring their hip forward. So Ober's test, everybody see me here? They're on their side, bring it around, and then let their hip fall back into neutral. And if they have tightness, if they're not able to get it into neutral position, then that's at least suggestive of a tight IT band. Trochanteric pain sign, that's if you're trying to fire their IT band and their abductors, and they have pain there. Of course, Trendelenburg test for weakness, and I think that's an important cause of hip pain. If they have weak abductors, it can lead to a lot of muscle dysfunction and imbalance. And then the external snapping hip, and that's the dislocating hip that you see, and then that's a test for it. Now we move to anterior, and it's not just anterior hip, it's anterior kind of pelvis area, and that's the abdominal muscles. The one that I typically do the most is going to be the resisted sit-up. So I get them to do a crunch halfway up, I press against their chest, and then palpate along the groin in the inguinal region, and then Valsalva as well. You're looking for athletic pubalgia, you're looking for inguinal problems, abdominal wall weaknesses here as well, and then tenderness directly over the bony prominences, so the ASIS, or the anterior superior iliac spine, or the anterior inferior iliac spine. And then subspine impingement, I think that it's a little difficult for me to differentiate the two, some of these, but if they have pain with direct hip flexion, then theoretically they're not hitting the labrum or crushing the labrum as much as they may be impinging on the iliac spine. Now we move posterior. You can do that with them standing. You can do that from and having them in a prone position. I found that if I'm trying to palpate the ischium and I have them standing up straight, everybody flexes their behind muscle whenever you push into their butt, which makes sense. It's kind of awkward. But if you have their foot on a stool, then it's a little bit easier. It brings the ischium in a position where it's easier to palpate. So I typically have them stand up for that. Any type of piriformis syndrome, which I think is difficult to diagnose, that's going to be resisted external rotation, but they can have severe buttock pain as well, and sometimes they can have nerve pain that goes down to their posterior thigh. And then ischiofemoral impingement, again, any type of impingement, meaning the two bones are hitting where they shouldn't normally hit, can cause discomfort and irritation in the soft tissue. So for me, hip pain 101, the labrum is painful. All right? So I find that that's a reality. I'm sure Dr. Cassio subscribes to that as well. And it can be painful to the patient, and it can be equally or more painful to the treating provider. And for me, this is a great cartoon that I borrowed from the internet. If you can see mine shaft canary, to me the labrum is the canary in the mine shaft. And I think as our understanding of labral problems and labral pathology grows, I think our understanding of this analogy increases. Because if we're treating just the labrum, then a lot of times we're putting a new canary in the mine shaft. And then we wonder in a year why they are having the same hip pain that they had a year ago. And I think for me the challenge is really defining and understanding the underlying causes. And so labral tear isolated for me is almost a diagnosis of exclusion, in the sense that if I really think I'm going to be able to get them better, I want to make sure that there's nothing underlying that's setting them up for this issue. So you can definitely have isolated labral tears. Some of the younger patients that we have and we see have isolated labral tears. Repetitive hip flexion or pivoting, anything you can do that rubs the front of that socket, or a dislocation event can cause it. And then also skeletal deformities, and that's really what we'll focus on some here. But you have this pain generated in the labrum, and then it's our job to figure out what's causing it. So the two most common, those are ones that we'll talk about mainly, are FAI, and that's femoroacetabular impingement. And so what that is abnormal morphology, so how the bones are shaped, plus abnormal contact. So you can have abnormal contact with normal morphology, and you can have impingement. It's still FAI, or you can have abnormal morphology but no abnormal contact and have bones that look like FAI that are actually not the impingement. All right, so it can be a little bit confusing. So not everybody with abnormal morphology has this condition. All right, so I call it femoroacetabular morphology, and I don't call it impingement unless they're having symptoms. So what it can cause is hip pain and labral degeneration. All right, there's two main types, cam and pincer. And so these are drawings from Dr. Bird back in 2011. And just to be confusing, and I apologize, anterior is actually the bottom part of the screen. Posterior is the top part of the screen, which he has them labeled. But you can see a cam lesion. So instead of having a perfect circle here, you have this bump on the top of the femoral head and neck junction. And you have a normal socket and an abnormal femoral head. And so when you rotate, you can see here, this would be a normal contour. This is abnormal contour with this bump. And so whenever you bring the hip into flexion and internal rotation, you're trying to glide this bumped area into the socket. And so just like a cam, which tightens in a certain position instead of having a circular dial, you're going to get this offset right here, and that offset is going to sneak into the socket, elevate the labrum, and then crush the underlying cartilage. And so this repetitive injury over time can lead to arthritis, labral tears, and certainly a significant amount of hip pain. So that's the first type, cam impingement. The second type is called pincer impingement. And that's where you have, if you look back, so look at the socket, this is basically on the socket side. So this is the normal socket. Now we have the abnormal socket that has this overgrowth or relative overgrowth of bone in the front. Same labrum here, and now you can see the femoral head is normally shaped. But when you go to flex it up, instead of being able to clear it, that bump of bone is pinching. And then the labrum is the canary in the mine shaft, if you will, and it's getting crushed between those two bones. Now, if this happens at 130 degrees of flexion and 45 degrees of internal rotation, unless you're a competitive ballet or dancer or gymnast or some reason to get into that position, you're never going to have a problem with it. And so that's why we see lots of patients that have these morphologies that do not have pain because they're not getting to those positions. And that's the same with this. You'll have patients that if at 20 degrees of internal rotation this will happen, but they don't have a reason to get in that position and they're not having pain from it. So FAI causes sharp anterior groin pain, probably the labrum, also the underlying cartilage, with flexion, internal rotation, and adduction. I'm sorry, I have that written wrong. And it can be lateral or posterior, so they don't always present with anterior groin pain. They do typically tell you, yeah, it's hard to squat down or cut back and forth. A lot of hockey athletes, which we don't see a great number down here in the South, have this problem. But typically you see limited flexion and internal rotation, and so that's where our impingement sign is helpful. So this is an example of femoral acetabular impingement radiographs. This is just a simple AP pelvis, and I'm not sure if it's projecting very well, but you can see the right hip. And this was actually a young lady who had bilateral hip pain, but left side was worse. I think I have it drawn here. So I'm going to draw the walls out. So this is the posterior wall. So we saw that on our cartoon. Posterior wall on the right. And then you're going to see the anterior wall on the left and the anterior wall on the right. And so what we don't want to see is this crossover. So this is the anterior wall coming in front versus here. This anterior wall stays behind it. And so this shaded area is that pincer deformity. Does that make sense from the other drawing? So you can see it somewhat faintly here, but that's why I've drawn it right there. Comes across. So that's the pincer deformity. And then this is her done lateral x-ray, and you can see a pretty good illustration of circular, 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 and then you lose it here. Everybody appreciate that? So that would be circular. This is a line down the femoral neck. The green arrow is approximately 45 or 50 degrees, and that would be about what normal is. And there's some debate about that, but for illustrative purposes, I've made the green line normal. And then this is where hers becomes aspherical. So you can see that where the bone leaves that circular rim. And so all of this extra bone here, relatively extra bone, is what we call the cam deformity. Does that make sense to everyone? Okay. And for me, I do obtain 3D CTs, and I think that it's helpful to visualize it because those deformities can really hide around the hip. It's a three-dimensional structure, and we're looking at it for 2 views, and we try to get a bunch of x-rays to evaluate it. But you can see here on our 3D view, it's a little bit easier to appreciate this extra bone or this relative extra bone here, and I've kind of outlined it. But that is the same area that we saw on the imaging. So the separate entity, but there really can be a lot of overlap, is called developmental dysplasia of the hip. Or hip dysplasia. And what that is, it's inadequate coverage of the bone that leads to mechanical overload. And the analogy that I give to patients, because if you say that to them, they're kind of not really understanding you, is it's like walking on a beach in sandals the first round, and then the same person walking back in the beach in high-heeled shoes. Okay? So you have the same amount of force hitting the sand with a sandal versus with the stiletto heel, okay? And so the sand would be your acetabulum and the heel would be your femoral head. And so if you have the same amount of force going through that, pressing against the acetabulum through a smaller area, it's going to cause increased pressure. So if you walk on the sand beach with your sandals, you get about this deep. If you walk with stilettos, not that I've done that recently, you're going to get about 2 inches of pressure, and you're not changing the weight of the person doing it. So people can kind of conceptualize, wow, okay, that is a big difference. So what happens if you don't have adequate bony coverage, if the socket is not as deep as it needs to be, then you're going to have increased pressure, and the cartilage can only take so much force before it breaks down. It usually affects the anterolateral rim and the labrum. So we get radiographs or advanced imagings, which I think are extremely valuable. So if a patient's had debilitating hip pain or prolonged hip pain and they've never had x-rays, or they've only had one view of an x-ray, there's a pretty high chance that we're overlooking the underlying problems for this pain. And so we have a few angles that we typically measure, and I've got them written here because some of the illustrations I have used these. But it's basically the lateral center edge angle is going to tell you how much socket there is on the front view covering the side of the hip. The anterior center edge angle is when we turn the hip image to the side how much of the x-ray shows that the hip is covering this kind of anterior portion. And then the acetabular index is really a value that tells you how steep the hip socket is. So we like it flat or almost flat, and that's a good bearing surface. The more inclined it is, the more it's a bearing and also a shear force. Does that make sense? And I tell people it's like you trying to walk on slanted ground. Part of the force is trying to go that way. And then we use extrusion index, and hopefully you don't see a lot of patients with that. That means the hip is actually coming out of the socket. And then tonus angle as well is another value that we use to show you the socket position. So this is an AP pelvis, and I just have an example here where this is the socket, right? This white line here, we call that the sourcil. And we're measuring from the center of the femoral head basically how much of the sourcil is in the good position. And we start with a central line, and then we measure out to the lateral edge. And you can see right here, so this is the kind of the key measurement is this angle. Normal is about 25 degrees or more. And so when we look at patients with hip problems, I'm always measuring these and hemming and hawing back and forth. Is that the real measurement? There is some variability, but this gives you a general sense. Then we turn the patient partially on their side, and we're measuring the front part of the socket as well, and we're getting that angle, and that's more than 20 degrees. So this comes into play. I mean, it's not something you need to memorize, but if someone has dysplasia and you're going, well, what does that mean? Only little kids get dysplasia. Well, no, these are the ones that are not bad enough to be problematic until they combine their activity, like that hip homeostasis picture, combine their subtle dysplasia with a bunch of activity, and that's usually when it presents. So from a treatment standpoint, and this is wrapping back up what I was trying to articulate earlier, is femoroacetabular morphology, meaning they have the differences in shape of the socket, does not necessarily equal femoroacetabular impingement. Okay, it's the morphology plus the impingement symptoms equals FAI. And so this really is abnormal contact, and it can be in extremes in motion or increasing the flexibility. And so the caveat or the pitfall in treatment for me is any type of rehab program where you're trying to increase their flexibility, if they have underlying FAI or they came for FAI, it's only going to make their symptoms worse. And so for me, a Pilates-based physical therapy program versus any type of yoga versus, yeah, we really stretched them out and now we can internally rotate 20 degrees because we, not knowingly jammed that cam even deeper into the socket. You have to be careful with it because you're not trying to increase motion. And so what we try to do is alter the position to relieve the contact. And so that can be through activity modification. So there's some offensive linemen. If you have some of those in your practice that you're taking care of and you internally rotate them and they only internally rotate 5 degrees and they're having some hip pain, you're never going to get them to 20 degrees. It's not a muscle problem. If you get an x-ray of these guys, they have a huge cam lesion. Usually one side's painful, the other side's not, and they both look the same. Getting these guys to position when they sit, this is impinging. If you can get them to come out a little bit, that may be all they need to relieve their symptoms. And that kind of goes against some people that want to make sure that you restore the anatomy. But some of these guys are in late high school, it's their senior year. Do they really want a surgery and be out for 6 months? And if they can change their activity just slightly, it may be all that they need. And then we do use steroids, particularly if it's inflammation and if you're combining it with the other modalities. I don't believe that injecting steroids and getting somebody back to exactly what they were doing without any therapy or without any modification will be useful. I think it's a short-term fix. But if you're having a lot of irritation from your condition and you're going to do some of these above programs, then I think it's a good adjunct. So there's not a lot of data, at least in the orthopedic literature. I'm sure there is more in the therapy literature about non-operative treatment for femoroacetabular impingement. And it varies from 0% being successful to 90% being successful, and we know there's some variability in the actual treatment algorithms. It's more successful for the mild deformities. So typically the patients who have mild changes in their bone and have more extremes of motion that they're trying to attain, if you can make a little bit of a modification of that, usually you can get their symptoms to go away. I would talk about postural rehab. The bones are not fixed in space. There's pelvic tilt. And so if you have weak core and you have more anterior pelvic tilt, you're effectively bringing that anterior wall forward more, and it's going to impinge at an earlier position than if they have a strong core and they're able to rotate their pelvis back when they come into hip flexion. And really, from a therapy standpoint, I have them avoid a lot of passive range of motion and stretching, particularly in the extreme positions, because I think that's only going to irritate those areas that we're trying to calm down. So from a surgical standpoint, what are we trying to do? Well, we've kind of real 4 goals. We're trying to evaluate the cartilage and the labrum, and we're trying to treat them. And we have to look for the underlying causes, basically, of impingement, or from a hip dysplasia standpoint, mechanical overload. So I think I have a few examples here. So the 2 main ways, hip arthroscopy, which has certainly come into vogue, and I think it's a great tool. You get small stab incisions, go home the same day. For me, it's the 4 R's of hip arthroscopy, what it can do. You can repair, you can reconstruct, you can resect, and you can release. And if you're very skilled, if you have high volume, Dr. Cassio doing this, you can do a lot of stuff with these 4 R's. So if you have a picture over here on the left side, this is an example of hip arthroscopy. You can see the socket is right at the peripheral margin. The articular cartilage is here, and then all of this raw bone, that's where there was a cam lesion on the femoral head that has subsequently been resected down. So you could do that very, very well arthroscopically. And if you look at this as the open equivalent before, and we can actually take the hip out of the socket safely, look at the hip, and you can see this area where the bone continues forward, and this is that same or similar impinging lesion right here that you can remove in an open fashion. Why do an open surgery? For me, it's the 5th R. You can do repair, reconstruct, resect, and release, but reorienting the bones. That's something that I've not been able to do arthroscopically, and so I think that if the underlying cause is malpositioning of the hips, then really the only way that I'm able to do it is through open surgery. So I think that 5th R comes into play there. And you can do that through a surgical hip dislocation, and that's an example here where we actually safely take the hip out of the socket and look at it with an osteotomy on the side. Or we do an osteotomy where we're cutting the bone of the proximal femur, which is this bone here, or a pelvic osteotomy, and I'll show you some examples. It's a very powerful tool to be able to treat some of these more difficult deformities. So their outcomes, very similar: open FAI surgery, arthroscopic FAI surgery, return to sport 70 to 90%, depending on which author you listen to, 80 to 90%. So they're very similar. I think short-term hip arthroscopy is easier to recover from, for sure. You don't have to do an osteotomy, which is a major difference, so you don't have to have a healing bone that you put back together. But if you have a complex problem, from my standpoint, what I tell them is very well done hip arthroscopy is equal to very well done open surgery. Mediocre arthroscopy is never as good open surgery, and good arthroscopy is always better than mediocre open surgery. So you have to know who you're dealing with, who your surgeon is, in the sense that are they picking the best procedure in their hands for my problem? Because a well done procedure for the right indications is going to have the highest chance of a good outcome, and trying it out is not going to be as well, even if the incisions are smaller. So for me, these are, I think, three examples of hip pain. So these are patients that all present with intra-articular hip pain. And the key really, when they show up for you for rehab, is defining the underlying problem, okay? So if the underlying problem is abnormal morphology from femoroacetabular impingement, like that first case, that was a 29-year-old female, intra-articular hip pain, had failed therapy, had failed intra-articular injections, had limited hip internal rotation, which always makes me a little more confident that you can make a difference. It's the hip pains with extreme rotation that you're just like, uh-oh, this is going to be a problem. Or the level 9 gymnast, beware of the level 9 gymnast. So for her, this is preoperative, and when we have those same images, so this is the line preoperative, and you can see the cam, and then this is the postoperative. It's not the exact view, but you can see the restoration of offset, and this was done arthroscopically. So that's the image up at the top left. You can see the red line is the front part of the socket, yellow line is the back part, and you can see this large area. And then you can see that this is not a circle. Same image or similar image afterwards, and you can see this part of that crossover area, so is what we call it, has been resected, as well as a contouring of the femoral head and neck junction. All right, so that's more of the straightforward entity. I wouldn't call it simple, but more of the straightforward has a good arthroscopic solution. This next one, we're kind of stepping up. Same presentation. Definitely will see you in physical therapy. This is a competitive dancer. It's like, competitive dancer with hip pain. Dr. Cassia's favorite. I'm a little more wary because usually they have very good motion. She's had mild hip pain for years, but she progressed her activities and then got to the point where she was unable to dance. She tried therapy, tried injections, couldn't get back to anything, anterior groin pain and a pinch. And she had an impingement sign, but at 30 degrees. All right, so if we look at her x-rays, she's 17 years old, and you can see, looking at her, this is an AP pelvis. And immediately, I start drawing these lines. So those are her anterior and posterior wall. Can everyone see that? The red and the yellow. Secondly, we need to do something drawing her lateral center edge. Okay, so if we draw these numbers and then we draw her acetabular index, we get the sense that, okay, 18 degrees and we want 25 degrees or more, right? So I've talked to her about the analogy of the sand and you all remember all that? Okay. And then looking at the side view, so again, we're trying to judge the depth of her socket. Same thing here. So when we draw these lines, and I don't have them written over, this is 17 degrees and we want it about 20. And then if we draw our circles, she loses her spherocity about 72 degrees. So she has hip dysplasia, mild, but impingement, mild. Okay, so the question is, what do you do with this, right? Do you treat her as an impingement? Do you treat her as a dysplastic? We have a CT, 3D CT, and again, you can kind of get the sense that there's a cam lesion there. And then if you get a pelvis 3D CT, you can see clearly here, all of this bone out here is not really there. And so there's a lot of the femoral head that's not truly covered, and you can see this on the lateral view. You want to see the socket come up and out and over here, right? So this is an important area, probably a centimeter or so that's not present. Now we get an MRI. She has a labral tear, all right? Remember the canary in the mine shaft. She has a labral tear. She has thickening of her ligamentum teres, so this is fairly robust. So you get the sense, okay, is her ligamentum having to work more to keep her hip in position? A lot of questions, not a lot of great answers at this point. So what do? Do we treat her as hip arthroscopy or do we treat her as some kind of major open surgery? So for me, I've been doing the combination where we look at the labrum and the intra-articular problems arthroscopically, and then if we feel like we need to reorient the socket, then we have the ability to do that through an open procedure. So that's what she had, and you're never 100% sure until you start the surgery. But once you go in arthroscopically, if you see these labrum, okay, this is the redness, and it's kind of red along the whole rim. Can you appreciate that on the view? There's a little bit of fraying here. And then when I take my probe, this is the side view. This is the socket side. This is the femoral head. Beautiful cartilage, socket, femoral head. But what you can do when you press on the labrum, it bubbles up this cartilage here. Can everybody see that triangle? Not the actual bubbles. I guess that's a bad analogy. But it buckles up the cartilage. Okay? And that's where the cartilage is becoming somewhat debonded from the bone below it. And you really start to worry about that because first you get this debonding, and then you can get a frank separation between the labrum and the cartilage, and then these flaps form, and then you have bad arthritis. So you don't want to see that, particularly in a 17-year-old girl. So she has early changes, but I think because of her extreme activities with dance, she's developed symptoms. Okay? So for her, she got that arthroscopy, labral debridement of that frayed area, but to me the underlying problem was the hip socket. And so she got what we call a periacetabular osteotomy, and it's where you make a cut into the pelvis here, you make a cut behind the socket, and you make a cut in the pubic ramus and a cut in the ischium. I don't have a video or pictures of it, but it's a much bigger surgery than being able to do it arthroscopically, but for her, I believe this is the right treatment. And you can see here, look at the left side. So she had bilateral symptoms. I didn't show you measurements, but now it becomes more apparent. You can see the socket is up a little bit here, much more flat. You can see the posterior wall of the socket is out to the side. The anterior wall comes in the front here. I don't think I have them drawn. No, I don't. And so we've reoriented. We basically cut the acetabulum free from the pelvis, and we changed its position to what we believe would be a normal range. It's a soft science. It's not a perfect procedure. And then we hold it in place and allow her body to heal. So the way I explain it to people, we wouldn't have to do the osteotomy if they could walk like this. All right, so what we've done, we've told their socket to be in this position when their body is in this position. That makes sense. So it makes walking a little bit easier because it's hard to walk like that for a long distance. So this is 4.5 months. You can see the osteotomy is healed, and you can see the front view much better from a coverage standpoint, and then a side view. You can see where we've covered the socket more in that position, and we've also taken off some of that anterior bump. She's returned to collegiate dancing now at 8 months. So her pain is better. She's not perfect, but her pain is much improved. This is another kind of my last case. I think this is a complex deformity. 29-year-old male, right hip pain, catching 4 months. All right, so you're immediately thinking hip pain, catching, awesome. FAI, I know how to do this. He's tried therapy, nothing got better. On the affected side, he's only able to internally rotate -5 degrees. So for me, that means 5 degrees obligate external rotation. So he can't even get to neutral on that side. On the left side, only can internally rotate 5 degrees. And he has fair motion. So he's kind of the tight guy. Again, send him to therapy. Don't want him to try to improve his range of motion because most likely it's a bony problem. So if you look at this hip, everybody appreciate this is a different picture than the young lady had earlier. Okay, you can see here, this is the posterior wall. Let's see, the yellow lines. Okay, the anterior walls, the red lines. Can everybody appreciate that? And then that zone in the middle is the pincer deformity. Okay, so from an arthroscopic standpoint, we can take that away, right, and restore that anterior wall on the medial side of the posterior wall. But they have the caveat, you've got to draw the other images. This is the side view. Oh, I don't think I drew my line, but let me just draw you here. You can see this point from here to here is sloping up, okay, instead of flat. And you can see if you draw a line from the center of the femoral head straight up and over, that angle is actually reduced. Okay, so you go, wait a minute, so he's got this pincer deformity, but his hip is shallow, I'm confused. It can be confusing, it can be easily overlooked, and the wrong treatment can be applied, at least in my mind, the wrong treatment, that can cause him big problems later. So he has this huge cam, which you can see comes out to the side of this view, all right? And he has this labral tear with this paralabral cyst. So his labrum's the problem, or the pain generator, or part of it. He has this big cam. See that? You can actually see the bone here and this extra bone on the top. And now if we look at his hip, do we do this arthroscopically? Do we do this open? The problem is doing this arthroscopically, you can resect, you can reconstruct, you can release, you can repair. So if you resect this area of the crossover, then you're going to make him globally deficient. So this particular case is a patient where his hip, he has a relatively normal size of his hip, but it's tipped backwards like this. So he doesn't have enough hip socket in the back, and if you take out the hip socket in the front, he's not going to have enough hip socket anywhere. And so unfortunately that has happened occasionally, but as our understanding of the underlying deformities improved, that has decreased. So he got a hip arthroscopy with a labral repair, right? We've got to fix that pain generator. We decompressed the cyst. He had this subspine that you can see here was impinging that knob there from a previous rectus avulsion. An open osteochondroplasty to recontour the femoral head neck junction, and a periacetabular osteotomy. All right, we didn't do anything to the front rim of his acetabulum. So this is the osteotomy on a side view. So here's the socket, and you can see the bony rim here, and then you can see this is the sciatic notch in the back. And so you're driving this osteotome between this border here and this border here, and you're using X-ray to look at it because you're deep inside the pelvis. But we've got to free it up with a cut here into that, and you can see, I think you can see a faint white line where that cut is there. So he got that and he got reoriented, and now you can see this point from here belonged way over there. So we've turned his hip anteriorly and increased his posterior wall. You appreciate the difference there. Removed that anterior wall without resecting the bone, so we've reoriented the position of it as well as repairing his labrum. So this is the view at 1 year post-op, so he's completely healed. And now you get a much bigger appreciation. Can everybody see the difference? Here's that posterior wall way over here. and now it's crossing right where we like it, or as close as I think we could get it. And then the anterior wall with this huge, quote, pincer, which really wasn't. It was just his anterior wall that was turned, and so now it's right there. And you can see his socket is much deeper than it was before that. Let's see. So anterior wall, posterior wall, anterior wall, posterior wall. And then the side view, you can see where he has the cam, subspine. We've removed that. We've helped the position of his socket on the side view as well. The osteochondroplasty, maybe not quite as generous as I could have been with it, but did improve his motion. He's back, no pain, no full activities, and certainly appreciative of what we were able to do. So I have one last bit. This is my public service announcement. I'm a pediatric orthopedic surgeon as well, and so from my standpoint, knee pain may mean severe hip pain. And I would be remiss if I was not here giving a hip talk and talk to you about kind of this one entity, and that is the knee pain Masquerader. We're in Louisiana, masquerade balls. Slipped capital femoral epiphysis. Has everybody heard of that, SCFE? Probably everybody, or at least most of you. Please, we don't want to miss this, because it's the one thing in hips that we can make a huge difference in outcome. You know, this FAI and the hip dysplasia can take years and years. If we miss it for a few years, somebody will eventually get the diagnosis. Well, this can cause lifelong debilitated problems in kids that are 14, 15 years old that don't have a great solution. So any adolescent, 8 to 14 years old with vague knee pain, or knee pain in general, we need to check their hip motion. If they're obese in that age group, think, could this really be the hip? So what they have is obligate external rotation with flexion. So that means when you flex their hip up to do your impingement testing on them, their knee and their foot cannot stay in line. Their knee always rolls to the outside of their foot. And it's not because they're tight, it's because the head of the femur has rolled off the back of the neck, and so all of a sudden that neck is sticking up and it bumps into the socket. So it creates a mechanical problem, just like femoroacetabular impingement. They have groin pain if you try to move it, or one side looks different than the other side. Any of those clues, you need to say, hey, have you had a hip x-ray by chance? Well, no, doc, my knee hurts. I don't know why would I get a hip x-ray? And you need to be thinking about it. Okay? If you see it, they need to be on crutches, they don't need to walk, and you need to find them someone who can help. So this is a kid, 2 months of left knee pain, no groin pain at all. Treated as a sprain, saw the orthopedic surgeon, saw their primary care doctor, and saw the physical therapist, and did not get better with it. And if you look on the pelvis x-ray, this is the right side, so this would be a normal hip, so it was left knee pain, normal hip and normal socket, and you can see the left side, and you can tell, even if you know, there's some subtleties here, but you can tell that the right and the left do not look the same. And then when we get a frog pelvis view, clearly you can see this normal shape. And over here you can see here's the shape, and it goes abruptly down here and comes abruptly up there. And that's actually the head sliding off of the neck. And I say it's the ice cream scoop falling off the ice cream cone. And that's an analogy for all of my patients that fit in this category that they can certainly relate to. And the reason it's important is not the delay in diagnosis. If they get appropriate treatment without any problems, then they can do very well. But when they go from a stable slip, meaning it's slowly moving over time, to an unstable slip, which means it pops off of the neck, then their avascular necrosis risk, meaning the likelihood of the head not going from a circle to a square, and then having to have a round hole and a square peg analogy. They go from a 0% avascular necrosis to about 50 to 100% avascular necrosis. And a total hip in a 13-year-old is not something that any of us really want to see happen. So this really is an avoidable disaster, but we have to recognize it and treat it in a timely fashion. So this is a case that we had of a patient who actually had some hip and knee pain, tripped in PE, and then was unable to walk. And so you can see this x-ray, right? Clearly everybody can see that this head is not where it's supposed to be, and this neck is actually hitting in the acetabulum. Everybody appreciate that. So he has an unstable SCFE, so the 50 to 100% chance of avascular necrosis. So what do we do then? This is a role in my hands for open surgery. So we're actually able to take the hip out of the socket, which I know sounds a little bit crazy, but we pin it. The ball should be up here, and you can see it's like a sun setting around the back. All right, this is the femoral neck here, and then you should see it up here, but it's not. It's around the back. So we actually pull it out of the socket, and then we create a flap of tissue, which we then release it off of the back of the femur. Okay, so now what we've done, we've opened it up. Here's the ball. Here's the cape, which this yellow line, the blood supply to this ball is all within this cape. And so this is the neck part of the bone. It belongs, if I had this on correctly, it would be up here. So we've allowed that to fall off the back. And then we recontour, we actually make some cuts on this bone to whittle it down so that it will accept this without stretching out the blood supply. And so then we go, okay, well, is the femoral head alive, right? That's the question. We're able to make a small drill hole into the head and use a Doppler probe like they use for an ICP monitor. And this is the flow of the femoral head with that Doppler. So we can say, oh, wow, there is some blood supply there, which is encouraging. And then we put it back in place. All right, this is him at 2 weeks, so with some screws and some pins. It's not pretty, but it's better than he came in when he presented. And this is at a year. So at a year, you can see complete healing. The head is circular. He doesn't have any avascular necrosis. He's returned to sports, no pain. This is a good outcome. It doesn't happen like this in all of them, but this is a good outcome. And you can see the pre-op and you can see the post-op. We don't want to have to do these because they don't all go well. I'm not going to show you every case that went bad. It wouldn't remember me very well. But these go well. It's much easier to catch them before they turn into that high-risk stage. So take-home messages. Serious sports-related hip injuries can present with knee pain. Honestly, if you take home one thing, that would be the one thing to take home because we can really make a difference in these young kids' lives. Overweight adolescents, always check hip motion. And then as a treating provider, really in any condition, but certainly in hips, determining the underlying cause of the hip pain, and you want to tailor that treatment regimen to return the hip to homeostasis. This is my email. If you have any questions, I'm available by email. Happy to discuss cases or whatnot. These are my little ones. And so if you guys have any questions, I'm happy to field them here. I think we have a few minutes.